Welcome to the Behaviors Book Club. We're a community of busy, research-focused BCBAs practitioners just trying to stay on top of all of the current literature in our field. This series is, of course, JABA in one take, where we break down a current article from the Journal of Applied Behavior Analysis and disseminate it for clinicians and practitioners like you and I. This article is from issue number 54, number 4, the fall edition. It's entitled Increasing Adherence to Standardized Rounding Procedures in Two Hospital Inpatient Units, and it was written by Nicole Gravina, Andressa Slayman, Frederick Southwick, Nicholas Mady, Elizabeth Harlan, Karen Lukos, Garrett Hack, and Nyla Reckerson. This was done at the University of Florida, and I happen to have a vested interest in the University of Florida because it's where I got my undergrad in behavior analysis, as well as where I live right now in Gainesville, Florida. So first thing to point out about this article is that many of the people on this article are not actually behavior analysts. I think that's really important to point out because this represents a really strong example of multidisciplinary work in our field. This was a analysis of rounding procedures in a hospital. So this was not about developmental disabilities. This was actually an OBM article. OBM, of course, stands for Organizational Behavior Management. And typically in the JABA publication, we don't get to see a lot of OBM research. They actually have their own journal, the Journal of Organizational Behavior Management. But I'm really glad that this one floated over because I think it really should open our eyes as clinicians to all of the different opportunities that BCBAs really have. You know, we don't have to work with the developmentally disabled early intervention style population. There's lots of other populations we can work with, and this is a great example. Nicole Gravina is a fantastic professor at UF, and she really preaches this a lot in other talks and conversations that she has with people. You know, ABA is so much more than this early intervention style field. So whenever we move into a different topic, I like to introduce the concept of wiggle room because I think it's really important. And my professor, Dr. Barrero, actually introduced it to me when I first read an OBM article, and it really made me look at the article differently. So I think it's worthwhile to talk about here. So the concept of wiggle room is when you're working with and when you're reading behavior analytic literature, we tend to get very used to very large effect sizes when you're dealing with the developmentally disabled population, when you're dealing with problem behavior reduction or skill acquisition. We want to see a graph that goes from 100% to 0%, or vice versa, of course, if you're doing skill acquisition. That isn't how it always looks in other styles of articles. I think a lot about contingency management research in this. So a lot of the work that Dr. Jesse Dallery has been doing, also at UF, the effect sizes that he gets for smoking cessation looks maybe more like 20% at baseline to 50% at maximum treatment effect. That's really significant, but I think sometimes we can turn our nose up a little bit if it doesn't go all the way up to 100%. And I think if we do, we're going to miss on some really powerful articles and really powerful treatment interventions. And that's the concept of wiggle room, allowing the data to be less precise, less believable. You know, we don't need everything to be perfect to still get a lot out of this data. And I think that when we start talking about the graphs and the results, I think it's important to note that they're not going to have 100% effectiveness. They're not going to have 100% adherence to their checklist. But what they've presented is still really important. And going from 20 to 50% in this population with these physicians that they're working with is really significant, and it has a huge effect on patient care. So with that small rant out of the way, let's move on to the main topic. This, of course, is a topic over bedside rounding. This is when all the doctors and nurses and relevant practitioners meet up and go bed by bed in the morning and talk about the patients, how they did over the night, how they're responding to treatment, and what the plan is for the day. As someone who has a pregnant wife who has been in the hospital a few times, I cannot tell you how frustrating it is as a patient to work, or not to work, but to interact in a hospital setting when there are inconsistent rounding procedures. Maybe it's because I'm so used to procedures and protocols in the research world, but it is so frustrating to be told that rounds are going to start at 10 o'clock and then not seeing a doctor until 1 p.m. Or even worse, not seeing a doctor until your nurse, who knows what's going on and knows the whole story, has left for the day because it's been a shift, and now you have to round with a new nurse who doesn't know the patient. So, long story short, personally, anecdotally, it's a really significant socially valid behavior to be targeting. And that anecdotal evidence has also been echoed in the literature. They found that inconsistent rounding procedures can lead to worse patient care. So more patient readmits, more patient complaints, and less successful hospital visits in general. So this is a socially valid behavior to work on with these physicians. So what's the solution? We know it's a problem. So now what has been done in the past? So similar to a lot of other issues with getting a whole group of people to do one thing, the attempted solution is to just standardize the protocol. So this can be things such as typically checklists or certain people leading rounds. There was a study done by O'Brien et al. In 2018, and they focused on a checklist that really pushed the nurses to the center of the rounding procedures, and they specified patient orders so the nurses could always attend. The nurses were always present. They participated and presented patient data, and they found that this showed pretty good success. However, it still wasn't consistent, and it didn't have a lot of maintenance that flowed into later times. And when the researchers weren't present, the behaviors kind of dropped off. But we know just by that study that these standardized bedside rounds do improve patient care, like I talked about. However, whenever you're dealing with OBM research, one of the things that they constantly bring up is that it's difficult to change existing behavior that has a long history of reinforcement. So you think about learning history. The longer the learning history, the more resistance to change may be present. And that's what OBM research, and specifically this article, is really dealing with. We have highly educated physicians and doctors and nurses, all who have been doing the same thing for 20, 30 years. And a lot of times, because there's different communities, so with the nursing community and the physician community, a lot of times the nurses may think that they have to do it this way because of the doctors, and the doctors may think that they have to do it this way because of the nurses. And there's just a lot of variables that are really difficult. And this is why you may not see that 0 to 100 effect size that we may want. And this is where the wiggle room comes in as well. So checklists aren't enough to change this very resistant to change behavior. Like I said, when analyzed in that O'Brien et al. Study, there was some improvement, but it wasn't consistent. And then many other articles, specifically Southwick et al. 2014, developed those checklists and things like that. But at the end of their study, 20% of physicians still completed less than 50% of the checklist. So they always found that there were certain physicians who were really resistant to change. So what can we do when we have a solution, but it's not being adopted? Well, that's a perfect place for organizational behavior management and ABA to hop in, because we can work on those tough to change behaviors, and we have interventions that have already been validated with multiple different communities. So ABA walks in, the OBM researcher comes in the door and presents the performance diagnostic checklist. This is an interview to identify workplace and environmental variables that impede performances. This was used in multiple different settings. Austin and colleagues in 2005, Gravina and colleagues in 2008, Wilder and colleagues in 2020. Originally developed by Austin in 2000, this performance diagnostic checklist is a way of identifying what in the environment is causing the deficit in behavior. This also has been applied to the clinical setting. So if any of you guys are clinical managers or clinical directors, or even business owners, the PDC, as it's called, Performance Diagnostic Checklist, is a really significant tool to be kept in your repertoires as well. It's an interview where you go through a set of questions related to the behavior deficit. So for example, you're walking through your clinic and you notice that there are multiple uncovered electrical outlets, or you notice that the registered behavior technicians are not conducting the prompt sequence in the right order. Let's go with the latter example. So they're not conducting the prompt sequence in the right order. So you go to their supervisor, the person who's responsible for training them. That may be a BCBA, that may be the clinical manager, the clinical director, etc. You go to them and you ask them a set of questions. Based on the responses to those questions, the PDC can identify if it's perhaps a motivation issue, the behavior is not being reinforced in the environment, whether it is a training issue that maybe you would recommend some task clarification, or maybe it was a prompting issue, something where the behavior technicians were trained, they were motivated, but there wasn't any environmental prompts to support that behavior, and many other things. That is the way the PDC works to identify variables, and that was applied to the hospital setting to begin to identify where the deficit was. These are highly trained physicians and nurses. They absolutely can adopt these practices, but the PDC can specifically identify and recommend treatments for when these things are not getting adopted. So the purpose of this article was to use the PDC and interview the physicians and the nurses and develop a set of procedures and interventions to increase appropriate rounding procedures by these professionals. They looked at 34 different physicians and 21 nurses over 2 units. Each unit had 36 beds, and this was in an adult hospital in Southeast Florida. The dependent variables that they were working on increasing was primarily the percent adherence to a standardized checklist per each rounding day and patient contact. So the checklist consisted of the temp mnemonic, which was developed once again by Southwick et al. In 2014. The items stood for different things that they wanted the doctors and the nurses to go over during each patient contact. Those things were tubes, exercise, monitoring, and pain. And within those categories, there was multiple different items. So I think there was about 10 or 11 different items that were required to go over every time you walked into a patient room. And because there are so many items, a lot of the doctors had concerns that this would increase the amount of time spent on rounds and therefore decrease the amount of time that they get to work on other necessary duties. So another dependent variable was the rounding duration, so the amount of time it took the doctors to start rounds and to end rounds. The first step was the first author, Dr. Gravina, did a performance diagnostic checklist with 2 physicians, nurse managers, and 2 charge nurses from each of the 2 units. Now, it is very notable that the PDC was a modified PDC that specifically looked at non-adherence and potential intervention components. In addition, it was also modified to be open-ended. So the PDC isn't exactly an open-ended intervention. It's more of a close-ended, and the participants who are receiving the PDC have to select different answers so that the PDC can appropriately select an intervention. Now, with Dr. Gravina's expensive OBM experience, they took advantage of her ability to freestyle and begin to ask open-ended questions that would really lead to a more targeted intervention, more targeted than a typical PDC. So think of it as the PDC was the jumping off point, maybe the informal QABF of the intervention, and then Dr. Gravina's specific intervention prescribed based on her experience was the functional analysis when we got really granular in the interventions. So there's a few different issues identified, and there was many more than this, but these were the main ones. Doctors and nurses had concerns about HIPAA issues, so talking about patient information when other patients were in the room. So they said that was sometimes a situation where they didn't feel comfortable sharing all of the information publicly. Duration was a really big concern, specifically by the physicians. And they didn't want to increase the amount of time spent in rounds. There was the difficulty in time scheduling. So many times rounds were scheduled at 9 a.m., which also happened to be when nurses were passing out meds for the day. So a lot of times the nurses weren't actually able to be at rounds just because of the scheduling. The physicians wanted the nurses to lead the rounds when they were there, but the nurses weren't comfortable with the information and didn't feel like it was their job to lead the rounds. So those were the big issues that these interventions attempted to tackle. So the interventions were divided into two different parts. There was a less intensive and a more intensive intervention. And this comes in line with a multiple baseline design, which we're going to talk about in a second. But what they really wanted to see was not only could we increase the behavior, but what's the least amount of effort that it takes to increase the behavior, which is a really important question to answer when you're dealing in OBM, because in organizational behavior management, you're applying your procedures on a massive scale. Instead of running a functional analysis for, 2, 3, 5 kids a day, for example, you're applying your prompting or task clarification intervention over thousands of employees at a massive company. Think Bank of America or Shands or Johns Hopkins. All have OBM researchers involved in their practices. So because we're applying over such a large intervention site, it's important to use the least amount of effort to get the strongest results. So that's why they were divided into a less intensive and more intensive intervention. So intervention 1, the less intensive intervention, simply involved task clarification in the form of an email that was sent out and different times for the nurses and the doctors to rounds. There was prompting involved to send that email. And then there was a weekly huddle in which every week everyone got together and the director led a conversation about what is going wrong with rounds and what can we do better, and what's going well with rounds and what can we continue on into the next week. Intervention 2 included all of the components of intervention 1, but an additional couple feedback components. So the feedback components was a line graph emailed of the unit's performance to the unit's nurse manager, and also positive and corrective feedback dependent on how the rounding went. So you can see that intervention 2 had a little bit more legwork. It would be difficult to provide line graphs of each and every unit's performance when you're applying this over an entire hospital. Clearly, that would be a lot of data to track and bring in. So intervention 2 was a lot more legwork. And the question is, it's very likely based on past research that intervention 2 is going to work because feedback is such a strong behavior change agent in organizational behavior management. However, is intervention 1, which is much less intensive and much more applicable, will that also increase behavior satisfactorily? So before we get into the results, we can talk about the design finally. They used a ABC repeated measures multiple baseline design. So there were 2 units, unit 1, unit 2, stacked on top of each other, and it was the sequence of conditions was baseline, intervention 1, and intervention 2. Each phase in the top graph lasted about 10 data points or so, and then that was a little bit more, maybe 15 data points in Unit 2, the bottom graph. In terms of experimental control, we're getting into the results a little bit. It was pretty solid. Was it perfect? No. I would say they had decent experimental control from baseline to intervention 1. Looking at the area underneath the graph the area underneath the intervention change. Intervention 1 to intervention 2 on units 1 and 2, I would say is a little less convincing. We're getting a little bit into maybe natural increases and wiggle room, but it's kind of hard to tell. So I might have to let you guys form your own opinions on that one. In addition to the multiple baseline graph, they also did data analysis, which included a simulation modeling analysis. This, and I quote because this is the first time I've heard of this type of analysis, it evaluates the likelihood that a random data stream has the same autocorrelation as the experimental data. So essentially they take a random set of data and they compare it to what the researchers got, and they see if it's any different. So they examine the effect size and they see if there's statistical significance. What they found was that, generally speaking, there was good success. There was an increase from baseline to baseline to intervention 1 in Unit 1 and Unit 2. And there was a moderate increase, not as significant. It maybe went from 40% to 70% from baseline to intervention 1, and then 70% to 75 or 80% from intervention 1 to intervention 2. So pretty good increase from baseline to intervention 1, a little bit less convincing from intervention 1 to intervention 2. One important thing to note is that adherence increased with no additional duration. So essentially this gain of patient care cost nothing to the physicians who were actually implementing the procedures because their time was the same throughout. There was also improvements in the unit plus the individual level. They did track the individual physicians and they saw good improvements there. And they noted that this was a great example of interdisciplinary work. And I would definitely agree with that. I think it's important when you're reading organizational behavior management literature or anything that's not specifically in your niche. Like if you work with skill acquisition and role behavior, to not immediately ignore an article that's based on severe problem behavior or OBM, because there's a lot of things that can be taken away from this article that I think are significant across our field. The most important one being the power of feedback and the power of behavior analysis to change adult behavior like this. We talk a lot about behavioral skills training and how that structured training style can really help parents and RBTs pick up on new protocols and new procedures being used. But I think that to expand, adding in that feedback, adding in that, prompting and task clarification also can really help RBTs to learn the protocols and immediately start making some really strong strides with the patients we serve. Finally, for my takeaways, throwing back to the clinical directors out there, don't be afraid to use the PDC as a powerful tool to identify procedures and barriers. They can and have been applied in ABA clinics. If you go to the original PDC article, I'm pretty sure there's still a download in the supporting information where you can download the full PDC and do it. You can. I don't know about the PDC-HS, so the Performance Diagnostic Checklist Modified for Human Services. I'm pretty sure I got a copy of that off of the Wiley website when I found that article, so I think you can get it there. I've used it before in the past. It's pretty cool, and it really can identify a really strong intervention. My second takeaway is to really embrace that wiggle room with your own personal experimental data. Clinical data is not going to be beautiful. I feel like I say this over and over again, and I sound like a broken record, but it's better to try and get data than just give up and don't go for experimental control at all. Clinical data, it's going to be messy, but it's important to try. And that wiggle room that applies to OBM, I also think applies to a lot of clinical settings as well. As my final consideration for this article, think as a BCBA, as a clinic director, whatever position you have, even as an RBT, what procedures are you personally resistant to change? These physicians took some extra work some extra feedback to really get them to change their behavior. So what in your practice have you just been resistant to change? And why? Has it been a long learning history? Were you an RBT at a clinic and you got all your supervision hours there and you just assume this is the way it's always been done, so that's the way it will be done in the future? I encourage you to embrace some change. Take some systematic data, make some systematic changes, and evaluate what happens. The worst thing that can happen is that you go back to your old way and nothing changes. The best case scenario is that you come up with a more efficient and better way to serve the clients that you work with. That's all for me today, everyone. We will be coming back on Wednesday in a couple days where we'll be going over our next article. Thanks so much for tuning in. Don't forget you can find show notes and additional readings at www.behavioristbookclub.com, and I will see you all there.